Hi.
Good evening, one and all. Thank you so much. Extremely happy to see all of you after big gap, actually a big gap. Happy New Year to one and all. Oh, we are getting greetings from Kenya also. Thank you so much. Happy New Year, one and all. Let's all let's all hope and pray that we have a great 2021 ahead of us. Good evening, one and all, to online dentistry free lockdown webinar. We still call it lockdown webinar. That's a habit. Thank you so much for coming in. Dr. Joby, are you here?
Yes, Ben, I'm here.
Yeah, we have a great crowd, almost reaching 200 in Zoom. I don't know about YouTube. Joe, are you there? What's about YouTube Live? Are we going good?
We're good. We're doing good, sir.
Perfect. Perfect. So, once again, from the bottom of my heart, from online dentistry, Happy New Year to one and all. The first program of online dentistry in 2021 kicking off right now. And the first program, interestingly, the topic wise, oh, come on, caries. What can these people talk about caries? We have been doing filling daily. My patients are so happy with the fillings I have done. Now, what can these people talk more about caries? Guys, welcome to online dentistry. Thank you for trusting us. Thank you for being with us all this time. Online dentistry, as you might be knowing, started off with the motto redefining dental education. We started 12 years before. Many are still thinking that it's a new form that came up now during the lockdown and all that. We started in 2008. We have conducted 122 offline courses all over India. Multiple centers, almost 13 centers all over India. But last year, when the pandemic hit, we changed our modality completely. We changed our modality from a from programs that make money. We completely took away that mentality. We started giving free webinars for the dental fraternity, completely stuck due to the pandemic. 350 odd free webinars conducted online from March 23rd, that's actually one day before the actual national lockdown by the government of India. From there, we are going strong. Started with two groups of our offline module. We have almost 54 groups at this point of time, with a website follower, YouTube follower, Facebook follower, more than 13,500 dentists all around the world. Guys, it is just because of the support of all of you. Thank you so much once again. Myself, Dr. Binu Abraham, orthodontist practicing in Kochi for the last 22 years. And my partner, Dr. Joby Peter, pediatric dentist, my consultant pediatric dentist for the last 13 years. We together formulated this concept called as online dentistry 12 years before. And with the support of all of you, We are going strong. Thank you very much. We have centers all around India. We have coordinators all around India. Offline program coordinators. But all the offline courses suspended for the time being due to the pandemic. But the good news is, March, we are starting our offline once more. That's exactly 365 days of lockdown. We are starting offline program for the first time in March. All details will come soon. Presently, we are conducting free webinars and paid webinars. Free webinars are all those 1 hour programs, the one you're attending at this point of time, 1 hour programs, packed with information which you can carry on tomorrow morning in your practice. That's our motto. Redefine dental education altogether. And you are going to listen to one of the free webinars at this point of time tonight on caries management. Free webinars. We have a free webinar coming up next month on dental crowding and its management. Whatever small crowding you see, what to tell the parents and how to convince the parents. Do not miss that program. How many times have you listened to parents telling, Doctor, my son's teeth little coming forward, the tongue pressure, can we make it straight? I am asking my kid to press and brush every day. Can we make it straight? Answer to all that will come in that 7th February, 8 to 9 p.m. Note it down, guys. Free webinar with certificate of participation. Do not miss it. And then on sectional orthodontics, 2x4, 2 bands, 4 brackets, you can do wonders. That's coming in March. That's a free webinar. Paid webinars. We are having caries management. Today, you are listening to a free 1 hour program by Dr. Joby on caries management. But we have a 1 full day program coming up on 31st Jan. Note it down, guys. Complete concepts towards caries is going to change with that. If you listen to Dr. Joby tonight, you will understand what we are going to do on 31st Jan. Dr. Joby is going to explain a little bit about what you're going to do on 31st Jan in this class. All the amount, the paid amount, everything is given there. Look into that. Go to the website, register if you're interested. Click on that particular brochure. You will be taken to a WhatsApp group. In that WhatsApp group, you will have case discussions, study materials, articles. Guys, if you're interested in learning, just go click. And next month, we have crowding. Non-extraction management of crowding. Doctor, I would like to align my son's teeth, but can you do that without taking out any teeth, doctor? Answer to that comes on 28th February. Note it down. And we have kept all the rates very nominal. If you look at the rates, the caries management rate is 1,800 rupees, which let me tell you is like 1 patient composite filling. 1 patient composite filling. If your rates are really low, I would say 2 patient composite filling. But that's not the way to go, guys. You're not supposed to do a 900 rupee composite filling, guys, wherever you are practicing in. So we have kept the rates very economical also. The non-extraction management is 3,750 rupees, which is again 50% of 1 patient appliance cost. And then in March, we have sectional orthodontics 2x4, cost is like 6,500, which is like 50% of what you can charge your patient, ideally, for a treatment of that type. That's how we have formulated it. Without affecting your budget, online dentistry has formulated everything. Thanks to the whole team working 24/7 behind it. Finding out the right costing, finding out the right curriculum, and giving the dentists all around the world the right knowledge. No marketing, no selling products, nothing, to the point. These are our contact informations, myself and Dr. Jobby's number. Feel free to contact us, WhatsApp us. If you're not in one of our WhatsApp groups, please put a personal message. We will guide you. We'll put you to one of the groups and you will be with us. You will get all the updates. That's it, guys. Thank you very much. Over to tonight's program. Let me introduce Dr. Jobby here. Dr. Jobby needs no introduction. Dr. Jobby, pediatric dentist, Malabar Dental College, head of the department, Malabar Dental College, Kerala. One of the finest pediatric dentists I have met. My pediatric dentist for the last 12, 13 years. He has changed the concepts towards pediatrics in my clinic. He is going to highlight you about the importance of holistic approach on caries. Over to you, Dr. Jobby. Dr. Jobby, perfect. You have shared your screen.
Yes, Binu.
Perfect. We have around 205 people in Zoom, and I'm sure pretty good number in YouTube too. All the best, Dr. Jobby.
Yeah, thank you. Thank you. Thank you, Binu. Thank you so much. Happy New Year to all of you. 2021 can be a change. I pray and I believe that we can change what we had in 2020 and we can put into practice in 2021. Today's topic is a very special topic to me. The mere reason is I have traveled across the world. I have interaction with the best endodontist. I have interaction with the best pediatric dentist. I have interaction with all sorts of faculty pioneers in our dental fraternity. What I felt is there is a missing gap when it comes with caries. I don't know where it has happened. Believe me, I don't know where it has happened, but there is a missing link when it comes to caries management. When talking to the best pediatric dentist, caries management, they talks a lot of things. When I talk to the best endodontist or a conservative dentist, it talks different perspective. But finally, you know, you can talk a lot of literature, you can talk lots of high funda stuff. I know this, I know that management, I know this management, but finally when it comes to apply in your clinical practice, you're practicing, your patient is sitting in front of you, you're seeing a situation, how to apply it, you go confused. If I say this, what patients feel? If I say this, will they accept my treatment protocol? Is it right? Oh my God, I've gone through all sorts of that initial hiccups that we can have when we see a patient sitting in front of you with a large caries lesion. That made me to go in depth. What is this? Collect data from everywhere. I collected data from everywhere. And if I present what I've learned and practicing and going to practice, I mean, this one hour is not going to be enough. Maybe a year you have to be with me to learn what I understood and I practice. Totally different, totally different. But the reward I'm getting now from the patients, the reward I'm getting from the patient who left me, went, and 10 years back, they came back to me. 10 years back, they came back to me, sir, we want treatment from you. And one picture which I've shown you is a testimony. In my slide, I have shown you a picture It's not a joke. It's a testimony. I was started treating her from 7 years of age. She left me. Now she is 18 years of age. She did orthodontic, everything she did. She came back with the father, and I'm treating her now. So this is the truth I want to share with you. I will take some time. Believe me, if you want to have some lunch, dinner, snacks, something, take it, relax, just relax at your comfort. Listen to this. It will change your practice in the coming years. If not tomorrow, but 2021 end, you will remember me and online dentistry for what I'm going to speak from each slide onwards. It's not going to be a black hole. It's going to be a resurrection in your practice, what you missed and what you implement. And believe me, you do not need to spend a penny more at the end of this webinar. For you have to be patient till the end of my last slide. If you have that patience, be with us. 2021, we are going to take you to a long journey on 2021, which can change your practice. A patient walking into your clinic, your assistant is running now and coming and telling, sir, there's a patient outside, sir. He's having a severe pain. Should I let him now or not? You are already having a patient, such severe pain, sir. Should I let him in or not? Now the COVID protocols, nothing, sir. He's crying and he's having severe pain. Want to see the doctor? Fine. Yes, we have emergency. That's what we do, services, right? So we have to attend that. We have to be equipped with that. Okay, we have that all equipments. We have all protocols to attend an emergency. So we tell the assistants, yes, let him come inside. Take the protocols. Let him come inside. So he's coming inside to see you. So you open it and see you a condition. What happened? Some severe pain, sir. The lower right quadrant, severe paining. When you see it, you can see a huge caries lesion there. There's nothing new. You know that, okay, dental pain means some caries is there or some cavity is there. You know that. But when you open the mouth and see, you can see a huge caries lesion there. So automatically the questions come from your mind. Since when you have this pain? Definitely. When you started this pain, you ask that question. They say, sir, a day before yesterday, it started, and yesterday night or tonight or tomorrow morning, it was so severe, I could not bear. What type of pain? Sir, it is full head there, this, back. He might say, I can't sleep, I can't lie down, I can't stand, I can't drink water. It's everywhere the pain is there. Even neck, shoulder, everywhere the pain is there. It's radiating and throbbing kind of pain is there. So I want to ask you, please come to the chat box. I hope you have not forgotten the chat box. Please come to the chat box and tell what will be your treatment option, just for fun's sake. Just, I hope everybody opened the video and I can discuss in personal with you, but it's not possible. Please come to the chat box. This is going to change your life. Believe me, your life, your practice is going to change. Can you tell me what will be your, yes, X-ray first, then RCT, X-ray, IOP and decide, Great, great, great. That's amazing. There are 240, 250 people. Amazing, amazing. That's great. That's great. That's great. I just want to tell one point here. Some people have said pulpectomy and crown, stainless steel crown. See, the patient age is around 47, 48 years of age. You don't do pulpectomy. Last week I went for a university examination valuation. There was a question which said that a 10-year-old patient had a trauma and the central incisor is fractured. What protocol will you say? Everybody started writing pulpectomy, pulpectomy, pulpectomy. 10-year-old central 2-1 getting fracture, pulpectomy, you can't do. You have to do apexogenesis or apexification or adult one. So this is an adult patient, a 45 to 50-year-old patient you're sitting in front of. You can see the tooth also. It's an adult patient. So RCT, whatever protocol, severe kind of pain, whatever you said is right. This is exactly the same thing I'm going to sell you also. This is whatever you said is the right one. IOPA, definitely. If there's so much severe pain, the patient cannot open the mouth. That's a different situation, but we might take an IOPA. An IOPA, definitely, you know how to read the IOPA. I'm not here to teach you how to read the IOPA, but you know, okay, it is involved it, then you will tell, okay, I will give you the medication. So much severe pain, as somebody said, you can give your inferior alveolar nerve block or something to relieve the pain, and so the patient will be comfortable, a little more comfortable, or medication you can give, give the medications, and then discuss with the patient. Don't you will discuss with the patient, there are only two options now, either root canal, which according to the IOPA says, or you have to go for extraction. And after that, crowns. That's all what you want to say. I know that. I know that. And all of you said exactly good thing about it. So this much is very clear. Let me go very simple. This much is very clear. The clinical scenario is a patient walking into a clinic with a severe pain, acute throbbing pain, cannot sit, cannot want to see you in emergency. And when you see the clinical situation, this is the condition, and you took an IOPA and you know what is the condition, and you know the treatment protocol for this. You told them the treatment protocols. That's it. Done. I'm done. We are all done. Then why are you sitting here? Then what Dr. Joby is going to tell? Something beyond. That's a suspense. That's a suspense. I want everyone to imagine a different situation. Forget about dentistry. Yes, 2021. Let's start 2021 without imagining dentistry. Forget about dentistry. Forget about your clinic. Forget everything. Now, just imagine you have good friends. I hope everybody has got good friends. Okay. One day, one of your friend called, oh, Joby, I'm having severe chest pain. Please, I'm severe chest pain. I'm in pain, severe pain. Your very close friend is calling you and telling you, I'm having a very severe pain. Joby, please help me. I need some help. So you took him, emergency chest pain. You know a little bit about it because chest pain is not simple. You know that. So you took him with an ambulance with the bobo sound. You took him to the hospital. The hospital guy, the doctors, the nurses came. Okay, when they heard about it, they took the first diagnostic protocol, an ECG. First diagnostic protocol, an ECG. A blood sample will be taken. They saw that ECG. They saw that some problem is there. Then they said the next protocol, they do an angiogram, they do all those things, and they find out there is a problem with this. And all in within a blink of the eyes, within a blink of the eyes, maybe 6 to 7 hours gap, or maybe 1 2 hours or half an hour gap, they say, we need a surgery. It's emergency. We need a surgery. There's no other option. You agree for it. You have to agree for it. And next day, today you can see he is out, he's safe and sound, he's out, but an open heart surgery was needed for him. Now, after the entire thing is done, then comes the result. Then comes the investigation value in front of you, saying that your friend had a severe problem. All the values were high, and angiogram and all the ECG was wrong. The echo had problem. The angiogram also showed blocks. There's only option to save him is to open up and remove, or whatever protocol is to be done. A radical approach, no conservative, radical approach at that point of time. That's the only option to save his life. Once it is done, the cardiologist will go, the physician will go, and he say that one more doctor will come And that doctor is the most important person in your life. It's not the cardiologist is important for you, not the physician is important for you, endocrinologist is important for you. There is one doctor will come after that kind of procedure, will walks in and says, nice to meet you, how are you? I'm going to change the protocols. If you want to live, if you want to see tomorrow, if you want to see your kids and family and enjoy, I'm going to change your life. And that patient, that doctor, going to give you a lot of things called dietitian, you can say. You might consider him not that much significant as considered to the cardiologists, open thorax surgeons. You may not find that important, let me tell you. But if you want to survive for the next years, that doctor is very important. The diet modification, the lifestyle, he will tell you why it has happened. If you would have taken care a little more, then drugs are all temporary things, and all those things he will give you clear instructions, but it's up to you to practice. That's all. That's your choice to practice it. Now, let's talk about dental setup. That acute pain, that unbearable kind of pain is equal to what the patient, your friend, was going through with that test. It's a life-saving situation there. Here, exactly the same thing the patient is undergoing here. But we have not realized the importance of it. Let me take into a different situation where a patient is very regular, very accurate. Every year he sees the doctor, do a yearly checkup and maintains everything properly. So one day when he did the checkup, the doctor said there is some problem, there's some borderline issue is there. So he all he has to say is modify, modify what causes the problem. I identified, modify that. Please modify that. No required for drugs, no required for surgery. Modify that. Modify your lifestyle. You went little more out of the way, so modify that. That's all. And he saved, conservatively managed that. This is what happening in our clinic. This is what happening in our clinic, where the mother or the parents or the patients calls up, doctor, when can I have an appointment? I just want to check up. Every year, whichever the world they are, they will come back and have a checkup with you. Everything is fine? Yes, it is fine. You're fine. You're good. My cap is good. My filling is good. No new caries. Everything is fine. So in that patient's mouth, even if a discoloration comes, patient notice that and says, doctor, what is that? Okay, it's fine. It's fine. Don't worry. I'm there. You should be ethically and professionally trained to say it is okay. It is good. I have checked it. It is good. So he will don't have any problem. Or if any problem arises, you tell him, see, I doubt there is some issue that has happened. I don't know. Maybe you're busy with your business or traveling or what happened, but there is something that is happening. It's better to see it or feel it. So do it, doctor. Do it. I know what you're saying. You do it. They will be agreed. They don't have any second thought about it. Next appointment, I will come and do it. Not in this situation he will ever reach. He won't reach into this situation. So here comes the question, what has happened really? Whom are we treating? What are you treating? In my life I'm practicing, what is happening? What change I require? What did I miss? How I can change my practice is that ask the question to us, whose fault is it? That lesion, that chronic pain, the patient is going, agony is going, whose fault it is? Is it your fault or is it patient's fault? So is dental caries happening in a patient? Is it a dentist problem or a patient problem? Can you come to the chat box and tell me whose problem is that? Please just make yourself that and tell whose problem do you think that kind of such a huge cavity that is happening. Great. Some says both. Majority of them are saying both. Excellent. Patient both takes equal part. Fine. Ah, that's a good question, Dr. Angel. You said if patient comes for regular visit and then it is happening, it's a dentist problem. Otherwise, it is both. It's an amazing reply I'm getting. But I just want to tell you one important thing. This is the problem with us. You are not confident in what is happening in your patient. Let me tell you very clearly, as somebody pointed out, if your appointment system, recall visit, regular checkup is happening, then it is your problem. Otherwise, let me tell you, it's not at all your problem, it's the patient's problem. I will justify in that in my next slide, because 95% of the people who are attending today told it is the dentist problem or both. I say it is not both. If provided, if you're doing all the protocols correctly, it's the major thing is a patient. Why? Because let me tell you, because dental caries is not as you think. It is not created by you and me as a dentist. It is created by a multifactorial problem. The multifactorial disease it is. Let's see that. Look, can you all see this picture A and B? If you can see picture A and B, tell me which tooth is more susceptible to dental caries. Can you just put in the chat box and say which tooth do you feel is more susceptible to dental caries? Oh, 100 after 100 is saying A. That is great. 100 out of 100 is saying A. So there should be a reason for that. Why? Because tooth morphology, if you see, A has got deep susceptible fissures compared to B, right? Is it dentist problem? Is it dentist problem? Because your patient has got a deep susceptible fissure, you made it. So patient has got a problem. Okay, fine. Next. What is this condition? Look at this condition. I have done a seminar. We had a guest faculty to represent a seminar. So I'm just going to go faster about that. Look at this condition. Enamel is completely collapsed and gone. While the enamel is erupting itself, it is gone. So you call it molar incisor hypomineralization. What is in this condition? Enamel is weak and defective by formation. It's a dentist problem. Is this a dentist problem? No, it's not your problem. What about this condition? A patient is sitting in front of you, has a caries in the posterior teeth, but when you see the mouth, you can see this condition. Is it dentist problem? Look at this patient. Even that mustard he had 1 week back. He had that rice, a sambar, and the mustard went inside. That mustard is there after 1 week also. You can see the smell, putrefying smell from the patient mouth. Is it a dentist problem? Lesion like this, does it occur in a day? It doesn't happen in a day. Used to happen, no problem, no problem. He kept on waiting, no problem. Oral hygiene is the dentist problem. So patient factors which depends upon the host, like the tooth morphology, habits, very important. Awareness of the patient that have to maintain a good oral hygiene for a good thing is a patient factor or a host factor, you can say about it. Oh, I love to go to Mysore and at that Mysore Park. The original Mysore Park, you get is amazing. It melts in your mouth. Just keep it, it melts in your mouth. Adayar Bhavan in Chennai will get an amazing Mysore Parks, and we love that. So very good, delicious sweets in India. It's available in India. Or the snacks. If a patient likes it, he has a craving for it, it's your problem. So diet which he's having, it's not your problem. It's all related to the patient's thing. And his frequency of snacking is also related to that. And the microorganism, the agent, everybody have, you have, I have, everybody have this microorganisms, a normal common cells in your mouth. It is there, it's present there. If you're born as a human being, it will be there inside your mouth. But once get bigger and other get suppressed, it's not your problem. It's not the dentist problem. I just want to share an experience with you. When the child was 8 years of age, I did filling, a filling of a temporary. I told them this is a temporary filling. You have to come after 2 to 3 weeks, maximum a month. You take an appointment and go. They took an appointment, 2 appointments they took. After 3 weeks, they took 1 month also they took, but they did never turn because that temporary filling somehow stayed, no pain for him. So the patient said, oh, nothing is happening. It's a milk teeth. No, why should I come at an 8 year of time? So they ignored. 3 days back, they came back. Now the child is 10 years of age. The child came back. And when I was examining, the parents still not worried. They are not worried. They did not know that there is a cavity is happening. They just came for a regular corona is over. Now movement started. They came. When I checked, my temporary was there. So happy. The temporary was there. His premolar started erupting. He's almost 10 and a half years of age. But when I had an examination on him, parents did not even see that doctor. That I did not see till now. I said food was inside. I removed all the food and I showed them this is there in this 10-year-old child. So from this to this, it has happened. 2 years time. Time. Time is another thing. Is it your fault that you gave appointment? Tell them they took 2 appointments. They did not come back. Is the dentist's fault it is? I don't think so. I don't think so. It's their fault. Let me tell you, damn it is. It is not our fault. We are believing in one sentence. We are believing in one thing, that all thing is done by dentist. So it's the dentist's fault. Your filling is not staying. It is dentist's fault. You did a filling and I'm getting pain. It's a dentist's fault. You one side you did filling, other side the patient is getting a caries. It's a dentist's fault. It's not a dentist's fault alone. It's not our fault. Okay, so my fault it is. Because it's a multifactorial disease. Dental caries is a multifactorial disease. You might have seen these diagrams. You might have did this triad become tetrad, and when in the center the caries comes. So you have a concept called Newton's concept, which was originally came from depth of causation of a disease in general population. We all know about this. I'm not going to detail about those concepts. You can read and get familiarized with this concept. That's thing. But we have got, but it is not your fault unless if you are not doing the proper protocols that it is done. That is why exactly I'm coming to the point. Have you made cardiology in your clinic? I'm not talking about any in your department or talking about in your clinic. Do you have a protocol of cardiology management as a specialty? Do you think endodontics is a specialty? No way. Because you don't have this specialty in your practice, that is why endodontics is happening. There's an amazing option or amazing aspect of dentistry which you have missed is cardiology in your clinic, because it's the bread and butter of a dentist. If you're doing an ethical and professional practice, this is the most important aspect that you should do. Currently, what is happening is overzealous treatment and its consequences that is happening. You are treating too much. You are treating too much or concentrating too much on the consequence of the treatment. The filling, the cavity, the pain, the patient is the consequence of the disease, but you are not treating the disease. You are treating a dental pain. You're relieving the pain of the patient. Oh, nice dentist, but you are not treating a real problem or disease. You are just treating the consequences of a disease. So understand the basic things and you apply it. Your clinic practice will change. All patients will be yours. Nobody will leave you. because it's less cost effective. All you need is to spend time and talk to the patient. That's all. And amazing results you will get. Look at this. Potholes that is happening. Potholes. To repair a pothole, you need a expert in that. And he will come and he will fill the potholes. And the tool for him, the tool for him is, the axe is the tool for him. With this, he clean and he fill it, just like some new materials he'll put and fill it and finish it and go. Exactly the same thing is now our dental practice currently happening. It's exactly clean it, fill it. And our tool is different. Our tool is little more polished, little more expensive look kind of thing. A hand with a motor running. You don't have to do anything. Just press it, it will run by itself. Or that's it. There's no difference in what you are doing and what we are doing. A pothole, how he repairs the road, and dentist repairing a cavity, there's no difference. Because you're thinking, okay, cavity is there, let me fill. Pothole is there, let me fill. That's it. And you have two devices to do that. That's all. So that is what fill it. The current concept, shut it and forget it. In dentist perspective, the current concept is drill, fill, and build the patient and forget it. So try to understand that what you are doing now is a repair thing. Like any mechanical shop, you take your car to a mechanical shop or a scooter to a mechanical shop, they do patchworks, they do some kind of services, some kind of mechanical thing they will do. And they said, okay, everything is fine, you can go. That's all. It's a repair center. So is your clinic is that kind of repair center? You repair all the patches, all the things, you fill and finish it and go. I'm not bothered about anything else. Or your center is a healing center. Your clinic is a healing center, or your clinic is a repair center, is a question, is a balanced thing that you have to see. Currently, majority of us, even I used to do, please let me tell you, I used to do this. Fill. One filling doesn't last, again fill it, again fill it. And next time patient said, sir, last week only you filled it, again you fill it, no charge, no charge. That is happening now also, it is happening. In many areas now also it's happening. Because it's a repair center. And all blame is to the doctor. You filled it, you did it not stay. It's doctor's fault. Or a healing center. Patient understand, yes, it's my fault. You do the best you can, I will do best I can do. If I can't do it, we'll talk about it. So first change your attitude into this disease holistically. You have to change your attitude. If you change your attitude, you can change the patient slowly. Patients are going to be the same. Tomorrow, Monday morning, same patient, same way the patient is going to be. They are not going to change. But if you have holistic approach, patient will slowly understand. Yes, doctor, you told. Yes, it's understood, sir. It's my fault only. But let's try one more. I will do whatever our possible thing is there. Slowly they will understand. They will change. They will come back to you. I still remember you told that it's going to happen like this. They will come back to you. Imagine it's a beautiful beach. Oh, so nice beach it is. So nice that you don't have to live. You want to build a house. Can you build a house on a beach, a sand? Can you able to build a house on that? I don't think it's going to stable there. It's going to stay there. Or in a marshy land, you can't. You can't build a stable building on a marshy land. Then my question to you is, how can you give a confident 100% permanent guaranteed 10 years, 12 years guaranteed restoration cap, implant, whatever, on an already weak structure, soft and weak structure? How can you give that? You look into the cavity, but you don't look beyond the cavity. Cavity is to be filled. I have the best composite. have the best DIC, best methodology, but the base itself is weak. How can you fill that? Will you build? Look at this filthy, foul-smelling kind of situation. Will you build a home next to that? On top of that, will you do that? You will never do that. You can't survive that. So my question is to you: a mouth which is not cleaned properly, is not even bothered of cleaning. I'm so busy, I'm traveling, I'm so much business, so much tension. Brushing is not proper, cleaning is not proper, approaching a dentist is not proper. Into that mouth, will you do a crown? You think that crown is going to stay there forever? Or an implant or whatever procedure in this kind of mouth, do you like to do that? So understand caries as a disease first. It's not a manifestation that you're seeing it is. You only see the consequence of cavity, that's all. But there is something else that is happening in this patient. It's going to happen. Even if your beautiful silver filling you have done, it's not going to stay there because it's a continuous process. Next tooth will become caries. Next tooth will be like that. You keep on doing it. So you should know that it's a dynamic process. It's keep on happening. It's not going to stay there. And the treatment mode is going to change. It's happening. It's already started changing. A lot of changes that happen. Then patient factor. Let me tell you, patient factor, awareness and need is very important. If patient does not understand, you have to categorize those patients. What I do is I categorize those patients. Okay, he is not understanding me. Let me categorize him. I tell him, no guarantee, I will do it. What you said, fine, do it. But other category, fine, understands, do it. So you have two types of patient there who understand your treatment, who says fine. Sometimes they don't come back fine, or say, accept, okay, doctor, you do whatever you want, you do it. This is what it is, okay, fine. But you told everything, informed everything, consent is there, you do it, no problem. Other patient, try to improvise it. That's very important. So there's our importance of clinical diagnosis of dental caries. Clinically, how we can make the patient aware about what is happening into the situation, which is not mentioned in any, it is mentioned but is not being taught properly clinically in a private practice setup. How you can make your patients aware about and need about it, give seriousness about it, improve, put some effort from their point to improvise it, to do a that is called clinical diagnosis of dental caries when it comes. So caries diagnosis, conventionally, what we do is, you all know how to diagnose caries is your probes, mouth mirror probe. You took that and you put a mark onto that and catch there is a caries is there. That's it. If there is a catch, there is a caries. If it's a dip, there is a caries there. And you say, oh, yeah, there is a caries is there. Patients, so many times patient says that, sir, it's a small dot. No, sir, it's a small dot. Is it caries? Its color is a caries. Yes, it is a caries. When you say it's a catch, you might even put the probe and try to pull it and say it's not coming out. It's supposed to come out very nicely, but now you can see, oh, okay. So there is a dip there. There's a catch is there. There's a dip is there. That's how conventionally we diagnose dental caries in current practice there. Now, can you all come to the chat box? Can you all come to the chat box? Look into this case. Can you see anything? Look into this picture of a 18-year-old child. Look into this picture of this outer enamel of this child, the label surface of this child. Can you say anything wrong with this child? Anything? Can you identify which is wrong for this child? Okay. Look the tooth. Don't look the gingiva. Look the tooth first. We are talking about the tooth. Yes. So I will put one more picture. What about this picture? Can you see something? Forget about the tooth. Look at the tooth label surface. Yes. Yes. Hypomineralized areas, white spot in cervical. That's great. you identified there is something that is wrong, it's not normal in that patient, right? So this is a case in front of you. You have multiple white spot lesions, you can say, or whitish thing that you can say in a patient that is there. So it is called white spot lesion. What you said is right. It's a white spot lesion. Enamel is whitish in color. By look, you can see that. What is this white spot? What is that? Nothing but enamel is demineralized. If you take the cross section of the tooth, you can see that enamel is like a powder stacked inside. It is not cavity form, but it is all demineralized, very weak enamel it is. Very weak enamel it is. Now imagine into this enamel. So if you take a picture, photochrome of this one, you can see outside of the enamel is okay, but inside that white spot, it is very weak. The dark color you can see, there is no mineral structure, nothing. It is very weak. But outside, it is nicely covered. The outer zone, it is nicely still intact layer of enamel is there. But inside that white spot, it is nothing. No structure is there. No mineral structure is there. It's very weak. It's like a shell. It is like an egg. You tap it, it will break exactly the same way. The outer surface is intact enamel, very thin intact enamel. Inside it's hollow, no nothing, no to support anything is there. So that is what you see as a white spot lesion. So what happens when you use a sharp explorer? What happens to this outermost structure? It will break. A frank cavity will form. That is what happens when you use a sharp explorer. You are creating a frank cavity. Now it's the dentist who having the problem. You are creating a frank cavity there. So what is a new shift in diagnostic protocols? Are you supposed to probe? No. Let's talk about this. The step one in the new diagnostic protocol for caries detection is not to probe. First and the foremost, step one is conservative way of diagnosing caries. And we used to have probe and mouth mirror. Now, along with the probe, you can see a brush, a soft to medium brush is there. So one option is, even what I give is, you will get brushes. When you go to hotels, you get a brush which is free and with a very low quality, or once use and throw, that's it. It just cost you 3 to 4 rupees, maximum 5 to 6 rupees, not more than that. You can buy as bulk and keep in your clinic. When the patient says about this kind of situations are there, no frank cavity, but doubtful situations are there, tell them to brush, or you just brush that part with the soft brush, clean the food debris. Don't use the probe. Probe will create a cavity there, because if it is an initial lesion, you don't know. So use that. Otherwise, if you have your micromotor with the brush bristles, slow speed, just run around the caries lesion. You are suspecting it rather than poking it. Clean and see it. What is there? So first step is that clean the tooth, not with the probe. Many times I've seen many of the juniors, I can see they clean with the probe. They can say a lot of food debris, but they are inducing a catch or a dip there. Then you observe it, clean it and see it. You have to observe it. That is the first step. Not probe, clean it either with the brush or the micromotor with the brush there. Step two. Step two is dry it. You should have a good three-way syringe, dry the tooth. Very important step. Once you clean it, you dry it. You are not using any premise or anything. Just plain bristles. That's it. Just to remove the plaque or the pellicle surrounding the tooth, and then dry the tooth. When you dry the tooth, a wet tooth, you can't see anything. When you dry, you can see a whitish discoloration, a white chalky appearance of the tooth. Naturally, you are not etched it. So it is already happening there. So that is called the white spot lesion, which I was talking, which has got an intact surface. Underneath, it is weak. If you poke it, it will break. A white spot lesion like this. If you put the sharp probe, it's going to be a cavitation. You are inducing the cavity there. So what is the paradigm shift in our diagnostic tools. What is a paradigm shift? From that probe, sharp explorer, okay, shepherd hook, from those things, we are shifted into something called loops, magnetic loops, visual observer. Very important. You should have a simple, very low expensive magnetic loops which enlarges the. You are using this. Don't think that if a patient is a dentist is using this magnetic loop, that means, oh, he's become oldie. He's become old. He can't see. That's why you please. That is not the reason. He is using it so that he can enlarge. He's doing a genuine and ethical practice so that he can see the tooth wider. Okay, any problem is that he can see that. Please do that. There's nothing wrong in that. Other, you should have microscope. You should have a microscope, take picture and see that. So one option is use a magnetic loops. Are there a good three-way syringe? You go to your clinic. Tomorrow you go to your clinic. If you are in clinic, just go to the three-way syringe and try to put the spray. You can see water also is coming. Water is also coming. It's a combined AC effect. If you put onto the air, AC effect. Put water, water will come. Too much water will come. But if you put on air, it's an AC effect. Water and air will come. No, that has to be changed. Dry air is required to dry the tooth. Very important thing. Second thing is an intraoral camera. Amazing things. Let me tell you, it can change your practice. This will give you all tooth 360 degree. You can go around and you can see around it. You can see that. That's an amazing thing. Intraoral camera. We are going to come with a half-an-hour session in our this month end. How to, which intraoral camera is the best, how to use, how to motivate, practice management with that, the pixels, everything we're going to be covered with that. It's an amazing tool that you should use in all patients. On the table conversion of the patient take place with the intraoral camera. That's practice management. We'll discuss about it. And finally, one more thing which is cost you 120 to 130 Indian rupees is a plaque disclosing, a dual plaque disclosing solution. Please note it down. Dual plaque. Any company. I'm not just saying. I use this. Any company. DPI has got another company which is cost around 80 to 70 rupees per bottle. You can buy that. Anything. Just buy and keep it. So old one will be disclosed as blue and newer plaque will be disclosed as pink. That is okay. But old one is important for that. You can show to the patient. With this, you take an intraoral camera, take the picture. Patient will say, doctor, when is the next appointment for scaling? In the next one, they will automatically understand my mouth. I am the problem, not the dentist is the problem. So a newer shift towards the newer diagnostic protocol. Now, how much you have to spend for it? Nothing else. It's all a part and parcel of your gadget. Nothing new heavy equipments you need to require. So the white spot lesions that is happening, it's an important thing. That's a beginning stage, even in the adult or in the pediatric conditions also. The white spot lesion is the beginning of dental caries. So even if you're doing a filling in a 3-6, just go into the 7-6. 3-6, 4-6, just go into the 4-6 or 3-7. Just put the air dry and see what is there. Are you getting a white spot on the fissures of 7, the next tooth, 3-7? Inform the patient. Tell them. Take a picture. Show them. See, that is also stabilizing. You want this to happen, that conversion happens there. That is what the importance of practicing this protocol. White spot lesion is the beginning stage. Don't wait for the cavitation to be formed. So then you can talk about what is the role of probe. Probe has got a role. I'm not saying that is outdated, especially blunt probe. Please, blunt probe has got a role. It's called tactile examination, tactile feeling of a cavity. A frank cavity already there. Now you want to know the base of the cavity. Is it hard or it is soft? Tactile feeling you will get. That is done with the help of this probe. It will easily give you a tactile feeling. Oh, it is very soft. Oh, it is hard. Hard means reparative dentin or reactionary dentin is there. Soft means the dentin is still soft. So if you go deeper, you will open up with the pulp. You never know. So blunt probe will give you a feeling of the base of the cavity. It's hard or soft. That's called tactile examination of a caries lesion. There it was visual examination of a caries lesion. So that is done. Both the conditions, you will get that. All these conditions, you might require a probe to feel the base, is it hard or soft. Depending upon that treatment or your decision changes. It's very simple clinical examination gives you a clear-cut idea I'm dealing with a hard base or a soft base or not. And especially one thing I want to tell you is buccal surface of a mixed dentition, newly erupted 6. If you feel white dried and if you feel whitish discoloration, please do not probe. Please do not probe. If you dry it and you feel it is whitish in color, please do not probe. Unless if you see a cavity is there, then only use that probe, blunt probe, and feel is it hard or soft, depth is too much or not. Please do that. Many of the times people just try to poke on the buccal because very common sight in a mixed dentition, pediatric patients, mixed dentition patient, you can see that. So you have cavities of different types and size are there. In a patient you examine, you have different cavities and size and shapes are there. Now, how to convince my patient? How to convince them that you require this treatment protocol? You require this is the best for that particular tooth and other tooth. How will you convince them? That comes the importance. The next part, how can I convince my patient? The treatment part when it comes. Definitely, you will take an IOP and say and show the IOP say that this much tooth structure is lost, this much part is lost. You start explaining to them very nicely with an IOPA. Let me tell you, patients does not know anything about this IOPA. You take a maxillary molar IOPA and show to the patients, believe me, they get confused. What is this? Is my tooth or not? Or is something else? It's your tooth only. They don't have any idea. When try to explain, they look at this is gone. They say, hey, doctor, what is this whitish color? Is it a cancer? What is this? I have not done it. What is this? They say, what is this? This tooth is also in, like that. The question they ask. They have no idea about this IOPA, whatever it is there. They don't, you took an IOPA, okay, say, oh, they shake their head, that's all. They don't understand anything about it. And some people start drawing. They're good in drawing. Take the pad, start doing, your cavity is like this. It is like this, that the patient will take the tongue and see, yeah, there's a hole there. It is now it is like this. They say it is now. They say, oh, now it is like this. It has become bigger, big side. It is small. It has become bigger. All those sorts of things you try to explain. What are we trying to do to convince the patient, to make the patient understand that there is something grave problem is happening. That's all what we are trying to do. But let me tell you, they don't understand anything. They know that, okay, something doctor saying, okay, fine, very seriously he's telling, so there is something wrong is there. I believe the doctor, that's it, nothing more than that. Let me ask you a simple example. You are taking someone to an oncologist, have a problem, any cancerous problem, anything you're taking to them. They don't blindly draw diagrams and tell you like this and this. They take a proper diagnostic record. They take an MRI, they take a scan, and they protect the scan, and they say very specifically, after the diagnostic things and everything, you are in which stage of cancer. They say that. They categorize it into stages. You are in this stage of cancer, you are in this stage of cancer, you are in this stage of cancer. You will be happy that you come early and you are early detection. I could do it, so don't worry, I can completely manage, guaranteed. You can able to tell them, they will tell you, they give you the confidence. Then say, oh, sorry, you are in the final stage, it's very serious, you are stage 3, it's very serious, you need to do a surgery and a radiotherapy, whatever. They will tell accordingly the treatment plan or what type of cancer they diagnose, and it's a very severe type of cancer. You have to do that. Now, why we dentists can do some kind of things and make the parents aware that you have crossed, you are not in the initial stage, you are in the final stage or the intermediate stage, you are in this stage. The option in front of you is to root canal or extraction. That's all. The option for you is this. The option for you is this. Other tooth are also in only stage 1 or 2. The one tooth is in stage gone. Remove it. But there are other tooth are all in the stage only. Why don't you want that tooth also to go? But patient has to grasp it, understand it. That is why this dental caries is not a disease that has happened in a day. It is a progressive disease and it's an infectious disease. It infects, if the primary dentition is infected, permanent dentition will get infected. If mother is highly cariogenic, son or daughter will get it. Father is highly infectious, the mother and the daughters can get it. Change has happened. Considering dental caries is not only the mouth problem, it is an infectious and transmissible disease. And it is not caused by an external source. It is caused by whatever present inside the patient, inside the mouth of the patient. The same common cells, same microorganism that is present in your mouth, in my mouth, in the patient mouth is there. All the human beings, the same microorganism which is already present there become active. No extra oral pathogen, no corona kind of something comes from outside. It's all present inside everybody's mouth. That causes this disease. So we can explain to them that it is caused by a pathogen and it doesn't develop by itself. It has got stages like a cancer, which you said. You are in which stage? Now you can tell your patient that you are in this stage only, madam. I can save it. You can tell them, oh, fine, final end is that. So we need a picture, visualization of a picture in front of the patient that, oh, you are only stage 1. Like I tell in the interceptive orthodontics, see, the yesterday's this happened, the normal overjet of a patient is 2 to 3 mm. Your daughter is having 10 to 11 mm overjet. Now you tell me it's normal or abnormal. Oh, sir, okay, it is abnormal. What can we do now? Already 11 years of age. What can you do now? Ah, now comes to the table. Now comes to my table. Let's discuss exactly the same thing. She says, sir, normally should be 0 or 1 is okay, but now that particular tooth is in stage 4. Only option is this, but other tooth are in this stage. Do you want other tooth to be in stage 4? No, sir. What can be done? What protocols can be done to prevent my rust teeth into come back to stage 0? So that is called progress of the lesion. A good sound teeth without any problem, it start developing into next stage with problems, and it finally ends up with either pulpal involvement with severe pain and extraction. So the patient, which I told you, a patient is in that stage, the final stage, either pull it out or do root canal for that particular tooth. Yes, in the end stage of the cancer, I can tell them you are the end stage, pull it out. That's the only option. I tell like that only. The only option, the best option with severe pain, pull it out. Sir, then they ask, sir, what about chewing in that side? No other teeth. Ah, okay. So you understood now? Fine. Then the option is this, and say, but what about the other side is also having the same? So then what you do is you do this first, and I will come back and we will start doing the other side also. It's guaranteed. There's a guaranteed patient for you. They will entire thing they will do from you, and then only they will go because they understood. So progress of the issue, we have to show them how this is happening. So that is why there are some simple clinical motivating and understanding kind of classification kind of thing that has come. That's what I just want to let you know, that when the tooth is sound and the enamel is sound, no caries all around the tooth, let us name that tooth as code 1. For stage 1, you can, if you want, you do it, or code 0, you can do. It's not 1, 0. Everything is perfect. No discoloration, no stay, nothing. No, you dyed it, no whitish thing. The tooth is sound. All around the tooth is sound. You call it code 0, a well sound tooth. What about this condition? This condition is almost what is happening there. Okay? whitish, you can see a whitish discoloration, that you can see a whitish discoloration. You can see that when you see the tooth, there's a whitish discoloration is there in the tooth. So that is called a visible change. When you dry the tooth, there is a visible change, a whitish appearance of this chalky white appearance. When you dry the tooth is there. Otherwise, it is not there. But when you dry, you can see a whitish appearance. Let us score as scored one. Means what? Caries has started. Caries have started the case. But that's all. No cavitation. But caries are started. It can be the buccal, lingual, any side. Caries has started. But once you dry it, you can see it is becoming white in appearance. What about this condition? I did not dry. I just asked the patient to bite. I did not dry. You can see the saliva all around it is there. Saliva is there all around. Without even drying, I can see there is a change. Distinct visual change. You have not touched the tooth. No probe, nothing. Just ask the patient to close, or when you open and see, it's a distinct change. Without even drying, you can see a whitish patch kind of discoloration that you can see. That is code 2. So it is a little more severe. Without even drying, you can see code. You can see, oh, you are in code 2, in stage 2. It's difficult. Next, enamel breaks by itself. Enamel breaks down by itself and get discolored. Enamel breaks down, cavitation that is formed, and it's discolored. Enamel breaks down and it's colored, but no visible dentine. Dentine you can see only in the enamel. There is no visible dentine with your naked eye. When you dry and clean, no visible dentine is there, but enamel is gone. Here, a cavitation that is formed. That is code 3. Cavitation that is formed. You can say you are in stage 3 now. Still you don't want. It's going to be next stage. What is the next stage? The underlying dark shadow forms in the dentine with or without enamel breakdown. You can see a shallow of dark shallow, maybe a mild breakdown at one point of the fissure and pitch. You can see a mild cavitation, may or may not be there, but you can see a halo underlying the enamel. A spread halo, you can see underlying the enamel. You can see there's a little bit cavitation, but you can see a huge halo surrounding the enamel, bigger halo surrounding the enamel. With or without enamel breakdown. It can be with enamel breakdown or without enamel breakdown. That's not a simple situation. That's called code 4. It's not a simple situation that you can see. I just want to show you different clinical situations. Can you see that? It's a small enamel break is there, breakdown is there, but in dentine you can see a halo. A halo you can see. That's not a simple thing that you see. It's spread. Now, I am not going to the spread of dental caries, but let me tell you, it's spreading from the enamel to the dentine wider. That is code 4. It's a severe condition. More towards the end condition, you can say. It's going slightly towards the severe formalities are there. And code 5, you have a cavity. You have a cavity, open cavity, open lesion, you can say. Open lesion, you can say. There is nothing. You just remove the foot debris, you can see the underlying dentine. You just clean the plaque or pellicle, you can see the underlying dentine. The enamel is gone. The dentine is exposed. You can see the dentine there. It is brownish discoloration or dark or whatever it is. You can see the dentine there. The point is you can see the dentine there. That is code 5, more severe form. Code 5. It can be light brown, dark brown, opaque brown, whatever. I'm not going into the details about it, but you can see the dentine. Just remove the foot debris, open lesion, you can see that. Okay. And finally, extensive distinct cavity with a visible dentine. There's nothing to see here. A huge cavity with visible dentine there. That is code 6. That's the last form. This can have with pulpal involvement or without pulpal involvement. That's depending upon time the patient comes to you, with or without pulpal involvement. You can say, you are in last stage. Only option is pull it out, or this is the only option, the best option for you, because you are in the last grade. With pulpal exposure, you can see, or without pulpal exposure, you can see the last stage, grade or score or code 6, you can see. Last stages of it. So all of you can identify in this patient that primary second molar, which cord it is. Can you come to the chat box and tell me what stage is this? It's primary second molar, what stage is, sorry, second molar, what stage it is? This D, you can see a halo, you can see a halo, a small and a small halo is there and a small cavitation is there. So which stage it would be? There is a cavity and there's a halo, you can see halo is there. So definitely it will be a stage 4. What about this? Can you tell me this D and first permanent molar, which stage it will be? Which grade or which score it would be? This 6 and 5. Yeah, 6, fine. What about this guy? He is already filled. So, but you can see halo. Is already filled, but you can see an halo in the enamel. That means secondary caries is still there. It's happening and spreading. And this is stage 6. What I said is right. Damn right. Your said is right. 6. And this is almost stage 4. You can see a halo because it's filled, but it's a halo is there around that. Fine. What about this one? Let's see this one. This is another case around 11-year-old with multiple caries lesion, we can see. Let's see from 2-1 onwards, what are the cords here? You can see there's a enamel which without drying itself or by drying itself, you can see a whitish discoloration. So it can be cord 3, a cavitation that is there. You can see a clear cavitation we can see on the lingual aspect of the lateral. Again, you can see a whitish discoloration there. Cord 3, cord 2, cavitation. There's a cavitation, cord 5, and again you can see such a severe condition that is there in both this child. Around 39 is the total score of this child. You can tell the parents 0 should be there, but you can see your son or daughter is having 39 infected teeth. Rather than telling 12, now you are telling 39. Oh my God, 0 should be the score. And now I'm getting 39 for my daughter. Then they'll get the seriousness about it. They'll understand the seriousness about it. Now, this is not set by online dentistry or Dr. Joby. This is called International Caries Detection Assessment System to motivate, give awareness, make the parents understand that the condition is more severe rather than if you say class 2, class 1, class 3, class 4, what the parents know. They have no idea what is class 1, class 2, class 3, and they don't understand. Here you can see entire tooth is been taken. Each tooth, labial, lingual, mesial, distal surface can be scored, and you can give them the value and tell them this is severe. This is not joke that you need to do. Even pediatric conditions, you can see this is a 3.5-year-old child. Parents is sending the photograph by the procedure called lift the lip, and I tell them you need to come immediately because this is severe. You can see that whitish discoloration all around the gingival margin. Severe score. It will proceed into this and it end up into this. Such a severe score, it will definitely end up there. So, poll number 1, all of you, please utilize Dr. Joe. Are you there? So we are starting the poll. We have done a poll. All of you will get to know how to manage these cases. We have already given this in our WhatsApp group. So many people responded so well. So we are going to start the poll. The first question is, which among the following grade do you think need dental innovation? So please put your view, which among the following grade do you need treatment innovations? Great. Great polling is going on. Dr. Joe, is it the end time?
Yes, sir.
Yeah. So you can share the result. So let me tell you, around 52% of the candidates said all of them need treatment. That's great. I'm happy. Around 220, and I don't know how much in YouTube told all 1, 2, 3, and 5 require your treatment protocol. That's great. That's a nice result. And exactly in our pre-poll before the launch of the program, we said almost that much people have already said the same thing. That's a great comparative result, let me tell you. So you are at the right place at the right time. There is a modality of treatment. We are going to discuss each modality, how to treat this in the next session also. So now, the problem with interproximal caries, we are all told about the occlusal caries, interproximal caries. The best way to do is radiograph. You take a bite-in radiograph, and they have a radiographic classification system. Please read about radiographic classification system. We'll be dealing all these things in our the month-end program in detail about how to classify all those things. Radiograph also will be dealing, but those people who are interested can read about that. If you can't see in the radiograph, other option is put an elastic separator, ask the patient to come back 2 to 3 days, then the proximal side visibly you can see. You know, you take a radiograph with this code system, you can say white patch is there or initial demineralization is there. Even in the radiograph, it is not visible. So best option would be put a elastic separator in between the tooth and visualize it after 2 to 3 days. So the treatment consideration, we are coming to the finals of the presentation called treatment consideration of each cases. So treatment consideration about dental caries started with long back for prevention. Dr. Webb is the first guy who said you have to extend the lesion maximum to prevent the extension of the decay. You have to extend. That's our tooth. If you start a pit is there, you extend a big one so that it doesn't come again. If it is a fissure lesion, extend to maximum area so that you can prevent that. That was followed by Dr. G.V. Black, who said extension for prevention. G.V. Black concept, extension for prevention was there. Make the tooth in the self-cleansing area, extend the lesion maximum, which was again in 70s and 80s. It was being replaced by maximum conserve the tooth. Do not extend the lesion, conserve the tooth, because newer material has come. So they started using constriction with conviction. But let me tell you, now the latest concept is minimal intervention, MID, which is proposed by Graham Mount. He's invented DIC. With this, we are all moving into minimal amount of preparation. And then came a traumatic restorative treatment and medical model of caries management. And finally, 2019 and 20, the latest concept is ecological model of caries management. So all this in detail, if you want to listen, come on to this month-end program. We will be dealing each thing in detail with clinically applicable technique. Let me tell you, I'm not going to make you to pass MD's exam. Just clinically applicable methodologies that you should have in your practice. We'll be dealing in detail about that. So it's not drill, fill, and bill. It is called clean, fill, and bill. The concept is changed from drill to clean, fill, and bill. As I go, you will understand what it is that. Let's talk about code 1. Okay, let's talk about the code 1 which we said. Code 0 is a tooth which is absolutely normal, no problem. But code 1, what is the treatment option for code 1? Let's see that. First and the foremost, patient level management, awareness and hygiene. That's a protocol. Again, I will discuss in detail about which brush, which paste, how to use the paste, how to use the brush, how to educate them. All those details are there, which is very important. But the code 1, the treatment protocol for a patient with white spot lesion is remineralizing agent, daily use of remineralizing agent, not fluoride. Fluoride cannot help at this stage. The limitations are there. You can refer the studies. You can say application of fluoride you can do at least once in a month, or you can say once in 3 months or once in 6 months, the maximum. But white spot lesion, if you want the patient to be a effective result, I will tell detail about it. But remineralizing agent is the important thing for code 1. So I have done a detailed class about it and we'll be again discussing it. Remineralization techniques, including your GC mouse or your ACP, your calcium amorphophosphate, all those things will come into play to remineralize sugar substitute, xylitol, all those things come into way to prevent a white spot lesion convert back into normal, which is not cavitation that is formed. So code 1 that is required. And this is a simple video to tell you, just a simple video to show you the use of GCMOS for adults, daily use. Imagine this is daily use for an adult who has got a severe multiple white spot lesion on the tooth that is present there. So poll number 2, Joe, can you start poll number 2? Poll number 2 is, poll number 2. Dr. Joe? Yeah, the poll number 2 is your preferred option for treatment for grade 1. Preferred option for treatment for grade 1. Fine. That is great. Yes, poll ended. You know, that's great. 83% said remineralization technique now because you listen. But you know, in our pre-poll, pre-session, 78% people said fluoride. 78% people said fluoride. For white spot lesion, the option is fluoride. So that is why the application of fluoride is not correctly done nowadays, because this kind of lesions cannot be prevented by fluoride. This need daily protection. You can't apply fluoride daily. So remineralization technology which has come is wonderful and working it nice. So that could be your modality of treatment when you see code 1 type of patient. Fine. Next, let's see the next code. This is called distinct visual changes even without air drying. So it is little more deeper. From the code 1, it's little more demineralizations happen. But distinct lesion with visual change, but no cavitation that has formed, white spot, even without drying, you can see the white spot. So that is called code 1. What is the protocol for that? Arrested. Now comes little more heavier methodology called you have to arrest the caries lesion. So to arrest the caries lesion, what are the options there? You have to do fluoride. This patient needs fluoride in the form of a gel, which is the one that I have discussed with you, gel from Pascal or whichever. APF gel is one of the one thing I use there, or varnish. One that I use is Fluor Protector, which is available in India. And that's an amazing product that you can use there. Fluor Protector, ampule available, you can use that. So which patient? Code number 2 patients. And another thing that has come, or SDF, which we'll be discussing in detail in our session, is use of SDF. It's an amazing product. And let me tell you, I told my junior doctor that this is very good, and he sent to his batchmates in all over Kerala, and they're so happy that this is working wonderful in multiple clinical scenarios. So I'll be discussing a little more time in detail about that in our coming up session there. So let's see the poll 3. The poll 3 was, what is your best option? What is your best option for the option for grade number 2? What is the best option for grade number 2? Yes, best option, because without any drying, you can see there is a white spot or something that is happening. You can see that in a tooth. You don't have to dry that. So arrest that. Fluoride is the best option. And oh, great, amazing. That is great. Around 70%, almost around 70% of the people are in polling, almost 67% are saying that arrest the lesion. That is great. That is exactly one. But let me tell you, in our pre-poll, in our pre-session, many of them said just to do improve oral hygiene, diet modification, that is more than enough. Do you think that will happen? Yeah, after 1 month, we can see that it will form a cavity. After 6 months, we can see that it will form a dentinal cavity. After 1 year, the patient will come back and say that, that tooth is paining with involving the pulp. Let me tell you, that is will happen. That is what is happening now. In those conditions which you said, improve oral hygiene, brush nicely, 2-time brushing, 3-time brushing, nothing's going to work there. So there you require the protocol which we mentioned, aggressively more and aggressive thing that you require. Now, what is the code 3? What is code 3 is enamel is broken down. Till now, enamel was not broken down. Enamel is broken down condition. What protocol will you see? Initial breaking down enamel, sealants is one option, or enamel biopsy. Another protocol called enamel biopsy. I will tell what about it later. So pit and fissure sealant is an amazing tool where you can use when initial demineralization, little bit of breakdown that has happened in the enamel, you can amazingly use with enamel pit and fissure sealant. That is one good option that you can do. So sealants like Clean Pro 3M ESP is an amazing product that you can get. Its color changes its color. Clean Pro 3M is a good product, or Helioseal F is also a good product that you can use, or pulp dent that has come called Embrace Wet Bone. Even in the wet atmosphere, little bit dryness is, wetness is there, it will seal by itself. And this product doesn't have a bis GMA, no chemical things are present. So in that way also it is a good product, but it's a little more expensive. If you want to buy, you can use this product. So this is before sealant and this is after sealant application. That can be done in code number 3. Now next comes something called preventive resin restoration. The enamel is already broken down. When you run the Explorer or you found one part of the pit is caries or broke down of enamel is there. Only one part it is there. What shall be done? That is called enamel biopsy technique or preventive resin restoration technique. PRR it is called. That particular part only you go with the slow speed burr, clean it, and rest of the part you fill with the sealant. So that part which is gone deep, you fill with a restorative material like a GIC or a composite, which is a high strength composite, or a GIC, resin modified GIC, and rest of the sealant, rest of the part of the fissure, you fill with a typical pit and fissure sealant. This is an amazing technology which can save the tooth and longevity of the tooth for a longer period of time, which we will discuss in detail in that. So let's see poll number 4. What is poll number 4? Poll number 4 is your preferred option of treatment of grade 3. Your preferred option for, okay, sealants, okay, sealants, good. That's it. That's establishing in your mind that sealant is done in code number, grade number 3 is what you do sealants. And additional to that, so nice, 80% understood that. Additional to that, if one point, if you find, then you can use enamel biopsy and sealant. So the combination of both can be done. I hope it is very clear to you. So, but in our pre-poll, 68% said that composite restoration, Philip composite, that's all. But this technique, the composite will block that area, but rest of this fissure, which is susceptible, will develop caries later years, and then you have to remove the old sealant, old composite, and club it together, then do a bigger one. So in order to prevent that, this technique will be very helpful. Now it is code 4. Code 4, the halo. You can see that discoloration of the enamel, with or without dentine discoloration, you can see the dark discoloration that you can see. So there is code 4. What will you do for code 4? Here comes minimal surgical management. minimal surgical management. Your MID, your ART, your sandwich technique, name those techniques come into play in this thing. Your preventive resin stealing might come a little bit. Sandwich techniques, MID, chemomechanical caries removal. You open it up and apply the chemical. Only the soft infected dentine you remove. Leave the affected dentine there. Tunnel preparations, ART, all those comes. I am going to deal entire thing step by step, each with typho and which real tooth models in the coming up session on this month, and about all these techniques which are so useful to that. Sandwich technique like GIC, which GIC, open sandwich and closed sandwich, so many things are there to deal with that. With cement, can I use a lightweight GIC or a conventional GIC? Which cavity I should do, lightweight, which cavity I should use? All those things will come there, and fill it within and out, finish and polling, all those things will be done. So guys, there's a change in tool for us. Till now we are telling drill with this machine. Now we are telling them scoop out the soft caries. No need for drilling also. Just scoop it out. What? No need. In Corona times, you mean to say no aerosol? Yes, no aerosol. Just scoop it out. So newer materials that has come when to deal with little more deeper lesions like this, minimal intervention, minimal conservative preparation. Materials like Carisol, Papacare, Brix 300, Cari, which are available in India, which is a very cheap product, it's a very good product available in India. When you use this product, you apply this product onto the deep caries lesion. I will be showing you video demo with step by step with extracted tooth in the sessions, and just scoop it out. The caries comes out like this. So simple, it comes out like this. And the affected dentine will be removed and infected will be kept behind there. So pole number 5. Pole number 5 is the next one, which is the option for grade 4. What is the option for grade 4? Ah, great. Thank you so much. You are listening to this. 89-90% have responded to minimal surgical management. Nice. That's a great value we are getting. Almost 86% says that okay, 86% says that it is that. That's great. Fine. So, but in our old thing, they just said restoration. In our pre-program evaluation, 83.5 said restorations. Okay. So which restoration they did not mention, but restoration. But here also 86% said the minimal restoration. So restoration you can do, but not extensive restoration. Minimal restoration will work. That's it. And next is code 5, which is nothing but frank cavitation. You can see frank cavitation. Here you go for conventional surgical management. Conventional surgical management you have to do, not minimal, conventional, because it's a cavity is there. So according to the material that you choose, here comes the material and the depth of the cavity and the symptoms. A lot of things come here. You have to decide that. Like a deep caries management, we are talking about not a small caries, a deep dentinal involvement is there. So a deep caries management, your cavity liners and bases become very pivotal role here. Your direct pulpating, indirect pulpating, all those things are very valuable here. In this deep kind of caries lesion, it is important. You remove all the caries lesion either by burr or the other protocol which I have told. The depth of the lesion, you need to use the probe here. Tactile information is very important. Is it hard, soft? All those things comes very important in this code session here. So it can be a direct or an indirect. Sometimes it can be a direct pulp capping. Do not worry. You remove all the debris, pull it out, and that exposed part give a dressing material like a GIC, like a calcium hydroxide. A lot of materials are there. You give them and fill it. Still, you are conserving it, the remaining tooth structure there. Sometimes even you might have to go for pulpotomy also, but still you are preserving the vitality of the radicular pulp there. That's the beauty of this methodology. So the medicaments, calcium hydroxide like dical, one of the most annoying material, but I'll tell you the simple way to use this. your MTA, your biodendine, and one thing that has come, like Teracal LC, is an amazing product, newer generation product that has come, and how to use this. All those things can be dealt in the end of this month session. So these are the material that is available to do your direct, indirect, and pulpotomy in case of a deep caries lesion, where you use this as a either liner or a base. So depending upon the material, you select it and then you fill with your conventional GIC or a composite, you can do that. So the lastly, poll number 6, the second last poll number 6. The poll number 6 was what is the preferred option for grade 5? Grade 5, you know now, it's like a conventional methodology. Okay, conventional methodology. What is the poll? I mean, what is the thing that you use? Oh my God, you got an amazing response. Let me tell you, everything 95% are saying is great for you need to use surgical conventional surgical management. Yes, you have to use that. But here early, say 78 was the people who said for this one 78%. Now you got 93.5%. That is great. That's 20% people understood now that this is to be dealt in a different way. That's great. And finally, code number 6, you have the option is either go for root canal or an extraction. According to the patient's affordability, you go for that. Okay. So the last poll of the day is what is the option? Can I get Dr. Joe? Can I get your method of diagnostic protocol for this condition? This is something tricky. What is your preferred diagnostic method for protocol? You have to indicate what is a preferred diagnostic protocol. This is a little tricky. This is required for the moment. So can you give 5 more seconds? 5 more seconds because it's a tricky question. 35. We will end the poll. 33, 34. Yes. Now you can stop the poll. Fine. Yes. Fine. Now that's a tricky question. 8% said indicate radiograph for all conditions. 3% said 2 to 5. And 28% said 3 to 5 conditions. Code 3 number to 5. And 31% said 4 to 5. And 20% said 5. And so the correct answer for this, let me tell you, from 3 to 5, 3 onwards, you might need a radiograph. But ideally, whatever I go for the majority, 4 and 5, unless symptom is not there. Okay, if symptom is there, 4 onwards, you have to go for a radiograph. Let me tell you, that is a safer side to get a pre-record. 4 onwards, put a radiograph, whether the patient have got a symptom or not symptom, go for a radiograph for 4 to 5. And majority said that in the total poll. That's a good sign. So 4 onwards, before putting your burr down, the halo is there, either buccal, lingual, whichever side, take a radiograph, make it safe, and then proceed from 4 onwards according to the code. So to summarize, guys, I'm done. To summarize, code number 1, remineralization techniques. Code number 2, arrest the lesion. Code number 3, sealants or enamel biopsy. Code number 4, minimal surgical management. And code number 5, conventional surgical management. And lastly, so this makes them see, sir, you are in code number 4. Next is just remove the tooth, or more severe it will be. Which one you want? So they will say, yes, sir, this is the best. I will opt for that. So starting for the caries management, old concept is just preservation of the extension. Just extend the cavity so that no more lesion occurs, because they do not realize it. Maximum extension gives better prevention. That was a concept. That is called web of causation. You know how a disease occur when this philosophy came. They changed into that tetrad and triad. You might have heard about Caries tetrad and all those things came. Then came sufficient component cost model. You call your Caries tetrad. The time and the patient factor, all those came to it, but it did not work. Then they came out with medical model of management, like the cardiac condition. You do not treat the symptom, treat the disease. Cardiac attack, then the pain and the block is not the real reason. His lifestyle, his way, his hereditary factors, his risk are the factors to be taken into consideration. You control them. That is called the medical model of management. And now, ecological approach to treat dental caries. We have gone one step ahead. Let me tell you, in 2021 onwards, believe me, dentist will be writing prescription of medicine for your patient to go to the over the counter medical shop, collect that package, eat that product thrice a day, twice a day, once a day. That changes the ecology of the oral bacteria into normal commensals. Pathogenic bacteria decreases and useful bacteria increases because of that product the patient is taking. Oral hygiene, brushing, flossing are not material, but this will change, and that's going to be the future of dentistry. So you are going to be oral physicians. That increases a good bacteria developing in your oral cavity, in your gut. Resistance and immunity will be increased. That's the future. That's called ecological approach of preventing this menace that can happen. So thank you so much. I took half an hour to 45 minutes extra because this is a topic which has to be dealt in an extensive way. This is just the tip of the iceberg. I brushed. Spend with us for 6 to 7 hours on the end of this month. Each protocol will be explained to you in detail. You can catch us in all this platform. We are there in the groups. Please do refer to your friends. We want to change the concept of dental caries, which is the bread and butter of a doctor or a dentist. If you do not do hi-fi stuffs, do just caries management ethically and professionally, your practice will change in long run. Thank you so much for the support given to us and the polls that you have taken pre and poll. I have shown you with evidence that where are we? It's all us to change. I have taken a little more time extra. Thank you so much for that. Over to Dr. Binu, if any questions are there. If any more questions are there, you can put in the chat box. One request is please do come to our WhatsApp group. Please criticize, tell about what you felt for this session. I can repeat this session how many number of times if our members request, I will do that, because past 2020, I have repeated many topics more than 20 times. And each time when I repeat, it will be changed. It will be changed. It won't be it will be more useful and more topics will come. So if you have any doubts, put in the chat box, come to the WhatsApp group. Please tell so those sleeping members know that what we have discussed today, how we can change a simple drill and fill and bill into clean, fill and bill concept. Any more? Okay, I'm getting so more. Oh, Dr. Bhumadi.
Yes, Dr. Jabi.
Yeah, this is our best New Year gift. Thank you so much. Has been any questions? Are there been any questions?
Yeah, questions are like, sir, I feel difficulty to differentiate stain and caries. Jabi, can you hear me?
Yeah.
Caries.
So that is why, that is exactly why I told you, with the probe, you cannot remove a stain. You cannot detect a caries. You can only make a hole there. So what I suggest you is use the methodology which I told you. Brush it. Use that micromotor and the brush and clean it. Then you see that you can see the stains will be removed, and you can see any part of the fissure there is a breakdown, and dry it and see there. And even the brush, there's a different types of brush are there, which I did not tell here. I told you I have not time. There are pointed brush. That's the one that you should be using. I will show you that brush. That is the best thing that you can use it and clean it, and then you see, dry it and see. When you dry it, believe me, surrounding enamel is appearing as a whitish, chalky whitish appearance. That means the fissure is automatically will be one step ahead of that. Is absorbing more proteins and more color. That's why it is appearing like more dark or light in color. So this is the catch. You clean it, dry the tooth. See the slopes of the cusp is whitish in appearing. If they are whitish in appearing, his caries is already started for the patient. You don't have to think twice. The fissure which you appearing is more problematic than the slopes, which is a soft surface. Anything else?
Sir, how long to use the remineralization paste for code 1 caries?
How long we have to use the?
Jobby, can you hear me?
Yeah, I can hear, but the voice was
Sir,
breaking.
how long to use the remineralization paste for code 1 caries?
How long to use, that depends upon each visit. When the patient comes, what I do is I dry the tooth and see the white spot is still persistent, or I'll compare it, and if it's reducing, finally the white spot when you dry, you can't differentiate. It will be like almost like a normal enamel, or with the saliva also look at no difference, and then you can stop, and no more new lesions are happening, and then you can taper it down. You cannot abruptly reduce it. You have to taper it. There's a protocol to taper it down, and finally you can reduce it, but that require follow-up and all those things. So usually 1 year, you can say.
Sir, we can use caries removal.
Yeah, go ahead, Guru.
Sorry. Sir, we can use caries removal material in code 5 as well, right?
Yeah, you can use that.
Sir, is scaling advisable for patients with many white spot lesions?
Scaling, no, there comes a catch here. When you are using scaling for a white spot lesion already present in the white spot lesion, what I suggest you is there is something called specific plaque hypothesis. I don't know you know about it. Some plaques are good and some plaques are bad. So you are telling that to remove the bad plaque and then you do that. So if there are too much of plaque are there, so you do selective scaling, not all the teeth. Selective scaling where too much of plaque is there, the big thick dark plaque you can see which is there, you remove that without much pressure. You remove that, and then you apply a fluoride or remineralization, and once it comes back normal, then once it almost normal, then go for a deep scaling or whatever it is. In that way, you may not cause injury into the tooth, because the scalar tip is even very sharp. It can cause, because of your undue pressure, it can cause. So to avoid that, I suggest selective gross plaque removal is done, and then you do this fluoride application followed by your uh, remineralization protocol, and then finally everything is done. The patient is come back to normal protocol. You can go for your gross plaque removal later.
Can code 3 have
Yeah.
WSL?
Can she explain what is that W?
I have no clue. I have no clue.
I did not see that. If
Can code 3 have WSL? Forget it. Sir, can we apply SDF on infected dentine?
Can you apply SDF on incipient?
Infected dentine.
You can. Infected dentine, you should be applying it, especially in the posterior tooth. You should be applying it. And the latest thing recently that is come is that even affected dentine also, affected dentine is good. Infected dentine is also, you can apply it. Sometimes what we do is you do not remove gross dentine, you apply it provided there is no pulpal exposure. Sometimes you take the radiograph and find out if the pulp is openly not involved, you can apply it. Next time when the patient comes, you just remove those infected dentine. Then you can see a little more harder dentine down there. Apply that also onto that. That makes it better because this product goes there and kills all the bacteria and makes it very harder. So there is no way they say that you have to remove infected dentine and then apply SDF. All you need to do is gross cleaning of the food debris has to be done, and plaque and pellicle gross cleaning has to be done. Whatever remaining, that on top of that you apply this, it is a good product that can be used.
Okay, now WSL is white spot lesion, Dr. Javi.
Okay.
New information for me also. So
Even
can code 3 have WSL?
Yes, you can have white spot lesion. See, the beauty of this coding system is you are seeing each tooth surface. See, first I'm seeing the occlusal surface, then I'm seeing the buccal surface, then I'm seeing the lingual surface, then I'm seeing the mesial and the distal surface. So I can have a code 3 on the buccal surface. I can have a code 1 on the occlusal surface. I can have a code 2 on the mesial or distal. See, that is a beauty. See, conventional class 1, class 2, class 3, see you, class 1 is a mesial cavity occurring on the occlusal surface. That's it, done. But what happens on the mesial distal, you don't know. This system specifically tell you, treat a tooth as a holistic concept. Each tooth surface can have a code 1, code 2, code 3, code 4, code 5, whatever it is. Each tooth have different codes. Sometimes you can see buccal surface only so much penetrated caries, even the pulp is involved. So that is code 6. Pulp is involved, code 6. Occlusal is fine. Mesial and distal is fine. Sometimes you can have code 6 and 5 on both surfaces. So that is the beauty of this is each surface of the teeth is meticulously evaluated and coded, and you get the value and you can treat accordingly. And I inform the patient this is severe.
Sir, what should be the interval between application of remineralizing agent in code 1?
Application of a remineralizing agent, you are not applying, doctor. Remineralizing agents are daily use. Your remineralizing paste, you ask them to over the counter product it is, or you have that product you prescribe and ask them to do daily. But you every month you do a checkup and compare what improvement it is there. That's all.
Can we use fissure sealant for adults?
100%. This is the myth that fissure sealant is only for pediatric. Oh my God! Please do refer to YouTube. Please go there. You can get so many adult fissure sealant. When you know that type of patient can turn into a risk category, you never know. So it can be done if you feel the patient as suppose imagine the patient is locked down. Even the adult has become high caries risk because they are inside the house, they started munching, frequent snacking. So turn the patient with high caries category. So you seal the fissure if it is there. So there's no rule. That's what the ecological and the medical model of management says, that risk assessment, caries activity and risk assessment taken into consideration, and any age group you can give this sealant. Depending upon each tooth is evaluated and holistically you treat them.
Dr. Joe, are you online? You want to check some questions from YouTube? Please do that. Meanwhile, all those who are here, please note, end of this month, Sunday, do not miss this one-day program on caries management. And the cost of the program is one patient's filling charge, guys. all that you're going to lose is one Sunday. It is not
Vinu, let
going
me
to be a
tell you,
waste because Dr.
yeah,
Joby is
Vinu,
going to go.
yeah, let me tell you, one patient fluoride application is we charge around 2,500 to 3,000, depending upon each condition, protocol we given.
I
I
know
don't know.
that's our charges, but I'm just putting it. Yeah, I'm just putting it generalized. It is maybe one patient's filling charge is all you need, but you need to spend one full Sunday. I think the time is more valuable than the money here. But that one full Sunday is definitely going to change your complete concept towards how you're doing daily, the main stuff called caries. Tomorrow morning, first case, I'm sure it will be something to do with cavity, but how you are approaching it, how you are discussing with them regarding the preventive part, that is what matters, guys. You can be a repair fellow, or I'm sure Dr. Joby talked about that. I had to go in between. Dr. Joby, you talked about the repairing
Yes.
guy
Yeah,
as well as the
yeah, yeah.
healing guy, right?
Yes, yes, yes.
Yeah, these are typical practice management stuffs, guys. Anybody can be a repairing fellow, but being a holistic dentist makes a huge difference. So be there on Sunday, last Sunday of this month, one full Sunday. Be with Dr. Joby and myself. I am personally coming in discussing about the importance of convincing a patient using an intraoral camera and all that. But Dr. Joby is going to talk real basics on how to even mix your glass ionomers correctly. I think your staff also should attend. A program like this, I'm sure in America, there'll be a separate rate for dental assistants, but we don't have that. We have a same rate for everybody. Joby, I think we should have a separate rate for dental assistants for that program on helping these dentists how to
Definitely.
mix the glass ionomers, how to mix the dicals and all that. Yeah, I think we
Exactly.
should work on that too.
Yeah, yeah, yeah.
Anyway, guys, anybody wants to register, please go to the website. All the details are in there. You can just click and you'll be into one WhatsApp group. Discussions happening in WhatsApp group. Learning materials coming in WhatsApp group. It's a dedicated group with a lot of learning happening much earlier than the class day, and that one full day, lots of hands-on. You will be learning a lot of stuff. And again, the cost is one patient's filling. We have purposefully kept it that economical to make sure that any junior, senior dentist should get benefited out of it, because this is something which everybody do. This is not orthodontics. This is not myofunctional orthodontics. This is basic filling which everybody do on a daily basis. Dr. Joby, I think we are done with questions. Dr. Joe, are you there on YouTube? You want to take some questions from YouTube? Go ahead, do that now.
Yes, sir. So we have a question from Dr. Amba Vaidehi. The question is, sir, if a child is having white spot lesion along with code 2, do we need to give remineralizing agent along with fluoride application?
That is a very good question, doctor. If the patient is in code 2 in some tooth and other tooth has got this one, so as a follow-up protocol, you apply remineralization agent, but fluoride at timely intervention plus remineralizing agent is required, absolutely necessary.
So another question from Dr. Catherine. The question is, sir, will SDF application with a floss suffice in case of proximal code 1 and code 2 lesions? How predictable is the arrest of caries?
See, let me tell you very frankly, the proximal lesion with the conventional many literature says that floss, you apply it and you get it, has got a limitation, because I've experienced this in clinical practice is that. So what I do is I keep a separating media, separating elastics I keep, and I tell the patient to come after 3 to 4 days. I apply flu. I mean, this in all the areas, but that particular area which I suspects that require this reach of that, I put a elastic separator and then come the patient. And when I remove that, I can easily apply with the brush. That gives me a better confidence and assurance that it is gone there. Flaws, you can, but I do not. I mean, in a severe kind of situations, I must say that a tip I can give you is you go for separation of the tooth and do it.
Thank you, sir. That's all the questions that are from YouTube, sir.
Dr. Joby, Dr. Bhanumati has said that you are always with us mentally and our hearts.
Oh, great.
Dr.
Thank you.
Bhanumati, I know this is from the bottom of your heart. Thank you so much for that comment. We appreciate that. Come to the WhatsApp group you are in, post that in there. Let others also get motivated. Get your friends come in there. And a topic like caries, come on, anybody into dentistry, even final year students can listen to what Dr. Joby just now said, because this is bread and butter of dentistry. And when it comes to the paid program, again, I'm getting some personal messages here. Why have you kept it so low, 1,800 and all? And I'm getting personal messages here because all our programs, like in the range of 3,000, 4,000. Guys, we have been approached by multiple composite glass ionomer companies to sponsor this program. We never took any company's offer. There is no company, there is no product sponsoring this particular program this month. This program is exclusively done by online dentistry for one purpose. Happy New Year 2021 and happy dentistry to one and all. Thank you so much, Dr. Joby Peter. Can we wind up? Can we
Yes,
call it
Bill.
a day?
Yes, Bill.
Please log on to the website onlinedentistry.in. Check out the paid programs. 3 paid programs announced there already. First quarter, Jan, Feb, and March. Jan is caries management completely. Feb, non-extraction, crowding management. And March is 2x4 appliances for early prevention or early management of crowding, all having its own significances and all having the rates being kept in such a way that one patient you do, that coach fee will be covered. But that one Sunday, you have to be dedicated. We are dedicated. We have almost 2-3 cameras watching and having live demos on these days. So you better be dedicated. Come over, be with us. Thank you very much. Good night, one and all, for being here in big numbers. Once again, Happy New Year from the team Online Dentistry. Dr. Joby, good night.
Good night. Good night. Good night. Good night, everyone. Take care.